Pharmacology. We're going to be looking at the different medications that you all can administer. Our drugs that we give at the EMT level are broken down into the ones that you can administer patient-assisted versus the ones that the patient will have. Patient will have patient-assisted, and then we will have some that we administer. Like aspirin would be one that we would carry that we administer. Nitroglycerin would be one that your patient would have a prescription for that you would assist them with. And as we move forward specifically for you guys, you're going to have to remember these are your drugs for EMT. Once we get to advanced, we get other drugs. So it's important you keep those separated so you don't mess that up on National Registry. We're going to talk about medication specifically, not in depth here, but as you move through, we're going to tear down some medications so that you understand them forwards and backwards, coming and going. We're also going to look briefly at assisting with IV therapy. And that's one of the things we're going to do in the lab today. We're going to spike some bags and do some of that stuff. Hopefully if I got the stuff out. If you don't have your drug cards, remember the drug sheets I gave you? You're going to need those. So you pull those out. As we go through this today, you can fill in some of those spaces that I tell you. I will tell you things that are not in your textbook. I think I put them all on the PowerPoints though. And you'll be responsible for all that information. If you leave a blank that we don't go over today, just hang on to them because when we go to the respiratory chapter, we're going to talk about your respiratory drugs. When we go to the cardiac chapter, we'll talk about your cardiac drugs. So you'll fill in the rest of the spaces as we move forward to the other chapters. Okay, medications that you can administer. Oxygen is the top of the list. Oxygen is a drug. It does require a prescription. You know, people can't just have oxygen laying around at their house. So it is a prescription. Aspirin is going to be another medication that you'll carry. Aspirin is not a prescription, but it is an important medication for which of our patients? Our cardiac patients. We do not give aspirin for pain. By the time it's doing its job, hopefully we found something else that works. So aspirin's not given for pain. Oral glucose, what do we give that for? Low blood sugar. Yeah, diabetic patients, low blood sugar. Activated charcoal. Who gets that?
Overdose or poisoning?
Yeah, poisons and overdoses or people that you really don't like, give them activated charcoal. Metered dose inhaler. That's going to be an item, a medication that your patient will have, that you will assist them with. Nitroglycerin. Your patient should have that. You'll always ask them if they have that. If it's a chest pain patient. And then your patients with allergies will have, oftentimes will have an EpiPen. So y'all know all these. These are all your meds. Do what? Not so much. That's probably a good thing, though. There's some paramedics you wish these were the only ones they gave. I shouldn't say that. Okay, oxygen. All the stuff you should be fairly familiar with. Oxygen is indicated for just about any patient. Any patient that has a pulse oximetry reading under 95%, they're going to get oxygen. But also anybody that's having a cardiac problem, any respiratory difficulties, severe pain, anything of any significance, you're going to go ahead and give them oxygen. But anything below 95, you should be giving them oxygen. But if you've got somebody just with an isolated pain somewhere and their pulse oximetry is 98%, it's not required that you give them oxygen. And that's a change from just a few years ago, so that's why we are emphasizing that. If you talk to paramedics, EMTs on your clinicals, they may say everybody gets oxygen. Well, when you go to National Registry, you're going to be asked to differentiate between who does need oxygen and who doesn't. Action, oxygen raises the oxygen, when you administer oxygen, it should raise their oxygen saturation in the blood. That's its action. Dose, we had that word, haven't we? Titrate. You know what titrate is? Titrate is a word you absolutely need to know, titration. You will titrate that drug for effect. That means if the patient has a pulse oximetry reading of 91%, you might put them on a non-rebreather. And if you get it up to 98%, the patient might be more comfortable if you switch them to a nasal cannula. So you titrate it, which means you adjust it to the effect that you want to achieve. So titrate is in bold here, so make sure you know that word. I don't want you to miss any words on National Registry because you didn't know what they meant. They're going to use medical terms, so make sure you're familiar with any of these that you hear, like exsanguination. Yeah, you know, that's one they would use on National Registry. And if you didn't know what that meant, you're going to miss that question, and I don't want you to miss it. Titrate? Titrate is where you adjust something for effect. So it's kind of like if you have a headache, if it's a really bad headache, how many Excedrin are you going to take? 2. If it's just a so-so headache, you might just take 1. That's titration. You'll adjust it for the effect that you want. For oxygen, there are really no side effects and there are really no contraindications. For a patient that meets, meets the indication, there are no contraindications. Aspirin. We carry children's aspirin for a reason. Any idea why we use children's aspirin instead of grown-up aspirin? They're chewable, so they're easy. Yeah. We don't carry water on the ambulance, so we're not going to be washing down any big old fat buffering aspirin. So yeah, they're chewable and they're very much easier to titrate that way. If a patient tells you they took 1 baby aspirin, that morning, well then you may complete and give them 3 more. So if you had a big aspirin, you might not be able to do that. So, okay, aspirin indicated for chest pain, cardiac chest pain, not indicated for any other kind of pain. My foot hurts. Well, here, let me give you 4 aspirin. Not so much. It's just for chest pain. The action of aspirin, and this is something you absolutely have to know, we give aspirin for its antiplatelet effect. It keeps platelets from clumping together. When platelets clump together, what happens? What do you get? Blood clot. You get a blood clot in a coronary artery, what happens? Heart attack. So we give aspirin immediately to anybody having chest pain. Now the dose, in Alabama and most states nationally, you're going to give 324 milligrams. 81 milligrams is the dose of 1 baby aspirin. So if you give that times 4, you're given 324 milligrams. I should have typed milligrams on there.
You said 81 was the dose of baby milk?
1 baby aspirin is 81 milligrams. So we give 4 most commonly. So we're giving 324. There are some side effects to aspirin. It does cause stomach irritation. If you have a patient that takes a lot of aspirin, it can result in ulcers. So if you have a patient with bleeding disorders anyway, you don't want to give them aspirin. But if they have stomach issues, ulcers, you don't want to give them aspirin. Or you at least want to call med control and discuss it with them. I'd rather have a little bit of a stomach problem than a heart attack myself. Contraindications. Your only true contraindications are going to be if a patient has a drug sensitivity to it. Now notice under contraindications I've bolded caution. If you have a patient, an asthma patient, you may ask them if they have any issues or sensitivities to aspirin. They have found that sometimes asthma patients, and here we're talking about you're seeing a patient with chest pain who they are also asthmatic. If they have a problem with aspirin, aspirin can actually bring on an asthma attack for somebody that's sensitive to aspirin. So from that standpoint, you just want to ask any cardiac patient if they have a history of asthma, if they have a problem with aspirin. So there's no real contraindication other than you just want to ask. And if they say, yes, when I take aspirin, my throat closes up and I die, then are we giving them aspirin? That would be a no. Yeah. If they just say, well, no, not really, then you're getting it. Next, oral glucose. Oral glucose comes in these funky little tubes, and they seem to come in different sizes. These say 25 grams. Some of them are 15 grams, sometimes 20 grams. It doesn't really matter. Oral glucose is something you're going to titrate also. Anybody here ever tasted this stuff? Okay, I haven't tasted it either, but they tell me it is like really, really bad. that you get some of that in your mouth and you want to be spitting it out. Some agencies will actually use cake icing. You know, it's straight sugar, isn't it? It's a lot more palatable and it's pretty, maybe pretty. Indications, we're going to give oral glucose to a patient with a history of diabetes who has low blood sugar. That's when it's indicated. So indication means what we give it for. The action is it increases blood sugar. Ta-da! The dose typically is just going to be 1 tube. This is not an exact science with oral glucose. Like the tube I wrote from was 15 grams. That picture said 25 grams. So you just give them a tube. Or sometimes you may have tablets. Some services are carrying tablets that they kind of dissolve in their mouth, like fizzies or something. You may have a patient where you may have to give them 2 tubes. Yeah. We'll talk about this at length when we get to the medical chapter, altered mental status. Side effects of oral glucose, there's absolutely none, as long as you don't aspirate it. A relative contraindication, if you have a patient that you suspect is having a stroke, they meet the other criteria of a stroke patient, and they have low blood sugar, you want to check with med control before you give it. It's what we call a relative contraindication. Imagine if you have a stroke patient that has, say they had an aneurysm that's burst in the brain. So that means they're bleeding in the brain. And you give them glucose, and it really jumps up their circulating glucose level. Can you see that as a problem? Any thoughts on that? I'm going to tell you a big secret right now. You know what that means? No? It kills tissue. Yeah, sugar's necrotic. If you get, that's why diabetic patients, you know, are diabetic patients are diabetics because they have high circulating blood sugar. And that constant high blood sugar circulating throughout the body kills their tissues. I mean, it rots it off. I'm sure you've heard of diabetic patients that have had to have amputations. That just rots their vascular system. They have a much higher rate of heart attacks. It rots their vascular system. So sugar is necrotic. That's why it's so important that people keep their blood sugar normalized. You know, when you give kids, you know, crap all day long, I didn't say crap. You know, you give them sugary treats all day long, their blood sugar is going up and down, up and down, up and down like this. And that's very destructive to the vascular system. It needs to stay constant, and it needs to be just enough that you can think without being up in the stratosphere. So sugar is necrotic. So if you have a patient that's bleeding in the brain, and we dump a bunch of sugar in the brain, what do we know about sugar? It's necrotic, so it's really bad for the brain. So that's why giving it to a stroke patient is relative contraindication, in that if you have real low blood sugar, it's going to kill you pretty quick anyway. So a physician might be a better call to decide whether you're going to give a stroke patient sugar or not. So it's just a relative contraindication. Can you think of any other time where you might not give oral glucose to a patient? What?
They're unresponsive.
Yeah, yeah. I'm sorry you're unresponsive. Let me squeeze some of this junk down in your mouth. Yeah, because it's necrotic in the vascular system. But can you imagine what sugar is going to do to the alveoli in the lungs? Just kill it. Just kill it. Yeah. So we certainly don't want them to aspirate sugar. So they have to have a mental status that's good enough that they can follow instructions. They can swallow. You know, with this, there's always a risk that they could go unconscious, you know, before they've choked that stuff down, in which case you got to be ready to suction that stuff out very quickly. Activated charcoal, this is another fun thing. Activated charcoal is used for people that have ingested poisons and overdose on certain medications. And it comes in several different forms. We give it in kind of like a slurry. So it may come, here, this is a suspension, and you have to shake this up and then try to get them to drink it. Sometimes you may have to mix it. Just depends on what the form that they have it in, where you are. We do carry these on the trucks. I've never given it on an ambulance. I have in the hospital quite a few times, but not on an ambulance. It makes them throw up. It's so nasty, it makes them throw up. And I hate that. Okay, here's your drug. It's indicated for poison ingestion. Any overdose of a medication would be considered poison. Action, it absorbs poisons in the stomach. It inhibits absorption in the body. Most absorption of medications, poisons, occurs in the small intestines. So it's got to get through the stomach and get to the small intestines before it's actually absorbed into the body. So if we can get it in the stomach, we've saved ourselves a lot of problems. The dose says about 50 grams or 1 gram per kilogram. About 50 grams. It's really whatever you can get them to take. This stuff is so nasty and it looks so awful that usually when you administer it, you have to put it in a cup, like a paper cup, with a top, with a straw that's opaque. Especially with children, they're the ones that most commonly you have to do this to. And they don't want to drink that, so it can be a fight. I'm not drinking it. Side effects, it's going to give you some nasty old black stools. Also may make you vomit. It doesn't make you vomit right away. So that's one of the problems with activated charcoal. You give it to a patient who's ingested something, you're not sure how long ago they ingested it. This stuff sits in their stomach for about 15 minutes. Well, for all you know, some of that poison is passed on to the small intestines. It's been absorbed in the body, and now they pass out, and they start vomiting, that black stuff. So side effects, black stools, of course, and then vomiting. So contraindications, altered mental status. This patient that you get to drink activated charcoal, they have to have a mental status that you have every reason to expect that it's going to stay decent for some time. So they have to have a good mental status. Another contraindication if they've ingested a strong acid or a strong alkali. So I've put a couple of examples here. Alkali, bleach is a very strong alkali. Drain cleaner, strong alkali. Acid, hydrochloric acid or sulfuric acid. These things have already rotted out the gastrointestinal tract when it's gone down. So you certainly don't want it to come back up and redo the damage. So if they've ingested strong acid or alkali, then we're not going to give them activated charcoal. If they got altered mental status, they're not getting activated charcoal. Y'all ready? The bronchial dilator or inhaler, meter dose inhaler, MDI. These are the little things that your patients usually have for what type of problem? Yeah, that would definitely be respiratory issues. Prescribed inhalers. Patients with asthma, COPD, chronic obstructive pulmonary disease, which includes emphysema and chronic bronchitis. Notice we always have chronic here. Chronic bronchitis, different than just regular old. You get a bout of bronchitis once every couple of years. These are people that have it chronically and they don't get well. The inhaler will dilate the smooth muscle tissue in the lung, so it dilates the bronchi. It dilates, it relaxes the smooth muscle tissue which surrounds those tubes, so it allows greater airflow through the lungs. The side effects, the bronchial dilators are beta agonists, and that's something y'all will need to be familiar with. Beta agonist, that means it causes a release or it has an impact on the beta receptors. And the things that beta agonists do, regardless of what the particular drug is, beta agonists will cause tachycardia, increases the heart rate, and it makes the patient jumpy. It's a sympathomimetic. It causes, the pupils to dilate, usually increases the respiratory rate a little bit, increases the heart rate. It's a sympathetic nervous system stimulant, if you will. That's what a beta agonist is. So the side effects, your patient gets a little jittery, the heart rate goes up a little bit. Those are side effects. They're usually not a problem unless the patient already is having chest pain and you add this to it. In that case, you probably don't want to use this, even if they're having respiratory distress, if you think they're having a heart attack. But anyway, beta agonist, it's a bronchial dilator. And we will go much, much more into all these medications when we get to the appropriate chapter. So, nitroglycerin, this is going to be patient-assisted. Nitroglycerin comes in several forms. Your patients will either have it as a tablet or they will have it as a spray. So these are tablets. The tablets are very small. And either way, on the trucks, we carry it both ways. Some of your patients in a hospital environment may have get a tube where it's like a little paste. Did I say something, Pam?
No. If y'all look on page 429, we were discussing this one.
Last night, the person,
We couldn't figure out what Tom was taking.
yeah, he's only has 4 fingers. Or 3 fingers and
Someone's
thumb.
kind of had to be a little about it, so.
Yeah.
Oh.
That's all. We didn't know if anybody else would notice that.
You know?
Well, at some point, you'll get the ITLS book, which has a girl without any panties on. Can't wait for that one to come up. So I guess this one's better. I only have 3 fingers. And it's got a glove on.
Yeah.
That's the medic shaking that out.
Yeah,
I don't know. It's pretty weird.
Yeah.
Yeah.
Anyway, I have to write Brady again. That's all I do. Okay, so it does come in several forms. This is a pace. If the patient goes in, they're having chest pain, they will measure this out like by the inch, and they'll put like an inch or an inch and a half or a half an inch or something. We don't use this really in the field. It's a hospital thing, but it is another form of the medication. But most commonly, your patient's going to have tablets. We carry the spray a lot. Specifically, nitroglycerin needs to stay in a dark, cool place. It deteriorates very rapidly. So that's one of the problems. Your patient may have some nitroglycerin that he's had for a year or two, and so it's most likely inert, and he tries it and it doesn't do anything for him. So we come to the rescue. Indication for nitro is going to be history of chest pain of cardiac origin. If the guy's been out moving a piano and now he says his chest hurts all over, it might be musculoskeletal pain. So you want to make sure that it's a cardiac issue. Now these patients that already have nitroglycerin, they already have cardiac history. So it's a good chance that they know exactly what it is. So you want to ask them, is this like you felt before? Is this your regular chest pain, or is this something different? Their action, the action of nitroglycerin is it dilates the coronary arteries. Now it also dilates all of the vascular system, but we give it specifically because it dilates the coronary arteries. So what happens to your vital signs when you have a widespread vasodilation, when all your vascular system dilates? What decreases? The blood pressure goes down significantly when you vasodilate. So say you had a patient that had a blood pressure of 220 over 110. Would you give him nitroglycerin? What would the nitroglycerin do for his blood pressure? Yeah, it's probably going to drop it. Yeah. But it's not indicated for that. So you're not going to give it for that. You're only going to give it for chest pain, cardiac origin. Does that make sense? So it dilates the coronary vessels. That's why we give it. Contraindications, it's going to drop. If the patient already has low blood pressure, and by low blood pressure, some of your textbooks will say 90, others may say 100. So I'm okay with 90 as long as you're sure you're getting the right blood pressure. So if their blood pressure is below 90 systolic, you will not give nitroglycerin. If they're taking medications for erectile dysfunction, like Levitra or Viagra and things of that sort, those already are very potent vasodilator. You add one more on top of it, and you could kill your patient. So even your women patients, you have to ask them if they're taking any ED medications. I know that sounds really stupid. I don't know. I don't know. There's some studies out there, they feel like it's probably something psychological where they think it helps them too. I don't know. But anyway, so contraindications, and the blood pressure is already low, you can't give nitro, or if they've taken any ED medications. And you have to ask them. I had to ask the minister on a Sunday morning one time, "You taking any?" He had, and he fell out in the shower. So yeah, let me give you that.
Oh,
So,
no.
they're people, what can I say?
Yeah.
Side effects, drops your blood pressure, gives you a headache very frequently. Now, if you've got patients that take nitro, you know, on a fairly regular basis, they're probably not going to see these side effects. Their bodies have acclimated. But as you go on in the program, you know, by the time you're at the paramedic level, you're going to be giving nitro to patients that have never had it before. So with that, it's more important that you get a really good history because they've not acclimated to it. So before you give a patient nitroglycerin, what position should you put them in? Yeah, you want them down somewhere in case they fall out. You know, in case the blood pressure goes to 70, you want them seated or laying. And the EpiPen, the auto-injector, we give this to patients with what? Anaphylaxis, severe allergic reactions. We'll talk about that when we get to that chapter. Okay, indicated for patients, it's prescribed for patients with history of severe allergic reactions. The action, it is a potent vasoconstrictor. Epinephrine causes vasoconstriction, which is good. With anaphylaxis, and we're not there yet, but I'm going to tell you, with anaphylaxis, two things happen. One, the blood pressure drops. Well, I probably shouldn't put it like that. Has anybody here got severe allergies? Anybody have to use an EpiPen? What are you allergic to?
Anything. Mostly, I use my EpiPen for wasps.
Oh, yeah.
I'm really allergic to everything.
Oh, you got your EpiPen with you?
No, it's my car.
Okay. Well, don't get stung in here. We try to keep the spiders at bay. If you have a severe allergic reaction, we get a widespread vasodilation. And you get the bronchioles constrict. Those are the two things that will tell you that it's anaphylaxis. So, what epinephrine does is it reverses vasodilation and it reverses bronchial constriction. So it does both of those things. It vasoconstricts and it relaxes the smooth muscle tissue in the airway. So it's a wonderful little thing. Side effects, it's a beta agonist. So it's going to increase the heart rate and the blood pressure. Y'all okay with all that? Some of this stuff, like I just wrote here, you're going to hear several more times. So, y'all ready? You staying awake? Okay, medications. Okay, now we're moving away from your drugs that we just talked specifically about. We're going to look at drug classifications just a little bit, not very much, but things that you need to know about giving medications. Okay, your drugs, there are several different names for your drugs. There's going to be a generic name, there's going to be a chemical name, and there's going to be a trade name. So the chemical name I've written up here, I'm not even going to try to pronounce that for you. Y'all can do that for me. Generic name, epinephrine. Brand name, adrenaline. We're becoming more and more familiar with generic names, but you'll need to be familiar with the major ones that patients may take so that you can recognize the generic form of that. Anybody know what diphenhydramine is? Come on, somebody knows diphenhydramine.
The hydro?
Huh? The what?
Hydrocodone?
Oh, that sounds good.
Hydro?
It's Benadryl. Benadryl would be the trade name. Diphenhydramine would be, the generic name. But that's important to know. Like if you take those Excedrin PM or Tylenol PM, if you look on there, it says it's got 25 milligrams of diphenhydramine in it. That's Benadryl. That's what makes you sleep. So it's good to know some of those things sometimes. What you need to know when giving a medication, you need to know what it's indicated for. I had a patient one time, we went because she done fell out. She was playing, I don't know, bingo or something in a big bingo hall. And I'm doing my assessment on her, and she's telling me her medications. You know, she's got an inhaler. She's got nitroglycerin. I mean, she's got them all. And I said, well, so what made you feel like, how come you passed out like this? She goes, well, I got up to go to the bathroom, and I felt dizzy. And so I sat back down, and I just fell out. And so I said, well, what did you do when you got up and you felt dizzy? You sat back down, right? She goes, yeah, I sat back down, and then I took one of my nitros. And I said, well, why did you take a nitro? You stood up. She stood up too. She was 90. She stood up too fast, and older people oftentimes their body doesn't respond that quickly. So she stood up too fast. She got a little bit dizzy. You know, her blood pressure was probably already low. She pops a nitro, and of course now she done fell out. So she took a medication that was not indicated. I said, did your doctor tell you to take a nitro pill when you feel dizzy and weak? And she goes, well, no. He told me to take when I have chest pain. Well, did you have any chest pain? Well, no. But you had it in your purse, so you thought you might as well take it, right? Yeah. So anyway, it was not indicated. So you have to know what a medication is indicated for. Like, and that's why I made the point about aspirin. We give aspirin for what indication? Chest pain. We don't give it for pain. So you got to know what it's indicated for and give it appropriately. Got to know what the contraindications are for each medication. So what would be the contraindication of nitroglycerin? Yeah, ED medications, right? Certainly. Anything else? When else is it contraindicated? When the blood pressure is low, below 90. That's right. Got to know what the side effects are. It's important to know the side effect because if you give a nitroglycerin tablet to a patient who's never had it before, and now he breaks out with this terrible headache, what's your response? Well, you know, that's not abnormal when you take nitro. It gives patients headaches. So you need to know the side effects so you recognize when your patient is displaying them. What's an untoward effect? An untoward effect really is a side effect that's not an expected side effect. It would be an unusual response to a medication, but it would be a negative response. Like if I took a nitroglycerin for chest pain and then I broke out in a rash. Well, that might be a very unusual side effect. But it would be a negative side effect. Might not kill me, but it would be an unusual but negative side effect. Okay, I'm not sure on this topic here. When we give medications to a patient, we're taking a very large responsibility upon ourselves. If you give a nitro tablet to a patient when it is inappropriate or contraindicated, you could kill your patient. You know, that little old lady that took that nitroglycerin, she could have killed herself taking that nitroglycerin. She probably already had a blood pressure of about 90 when she stood up and got dizzy and sat back down, and then she takes some nitro. She could have killed herself. So we take a heavy responsibility when we're giving medication. So we have to know indications, contraindications, actions, dosages. There are so many dosaging errors out there. We just have to know our stuff. Got to know the medications. You got to know what it is they're supposed to do. Like when I say it's a beta agonist, you need to know what the side effects of a beta agonist are. So that if you see a patient, she's taken some, she doesn't know what she took, but she's showing those tachycardia, she's jittery, that sort of thing, then you might think, oh, you're probably taking a beta agonist. You got to use your own judgment sometimes, thinking things through well. Okay, in order for EMTs to give medications, we have to always make contact with med control. That's just one of the things we have to do. We've got offline medical direction and online. What's the difference? What's offline? Those are going to be your protocol, something that's written down. Can you think of one of the medications that we give under protocol? Oxygen, exactly right. Would nitroglycerin would be under protocol? No, we're going to have to make physician contact to give that. So offline is going to be when you don't speak to the physician when you go along with your protocols. Also, they may be called standing orders. In this circumstance, anytime you have a patient with chest pain, you're going to give oxygen. That's standing orders. With online medical direction, you're going to actually phone the hospital and make contact with the physician. Now, your protocols require that you speak to a physician. Some services might be okay if you call the hospital that you can talk to a nurse about that, or that he may transfer orders to you. That's going to be between you and your service. When I call to talk to a physician, I'm talking to a physician. When you receive the order, when you tell them what's going on, why you feel like you need to give this medication and ask for orders to give it, then you want to repeat the order back. If you call in and say, I've got a 78-year-old male, he's got a prescription for nitro, he's got chest pain, 8 out of 10, he hasn't taken any of his nitro today, his blood pressure is 140 over 80, he's not taking any erectile dysfunction medications, can I give him some nitroglycerin? And he'll say, or she'll say, yeah, give him up to 3 doses provided his blood pressure stays adequate. Say, okay, thank you. You said I can give up to 3 doses provided the blood pressure stays adequate. That's right. Okay, bye. So you repeat, listen for the order, and then repeat it back to make sure everybody understands it. Ask for clarification. I had a doctor years and years ago that says, just keep giving him nitro. You can give him up to 10 or 12 doses if you need to. I'm like, okay, 10 or 12 doses, just as long as the blood pressure stays up. He said, yep. I went, okay, better drive fast. I'm not giving 12 doses to this guy. Okay, your patients have there are 5 rights of medication, and this cuts across all disciplines. You've got to know if you've got the right patient. Now, that also means the right patient for the right medication. Is it prescribed for that patient? Is it the right time to administer this medication? Some medications, for example, the inhaler. The inhalers, the normal prescription gives 2 puffs and then no more for 4 to 5 hours, because that medication has a long half-life. So that amount lasts for a long. It's kind of like you take an Excedrin that says, take one every 4 to 6 hours. You shouldn't be taking one every hour. There's that time frame. So you want to make sure that it's the right time. Epinephrine, for example, has a very short half-life. So we may actually give epinephrine every 3 minutes based on why we're giving it. But the EpiPen, you may use several EpiPens in a short amount of time. So is it the right time? Is it the right medication? My patient that took the nitroglycerin, that was definitely not the right medication. So you got to make sure that it's indicated for what's wrong with your patient and that you give them the correct medication. The right dose. We give 2 puffs on the inhaler, but for the nitroglycerin, we don't want to give them 2 squirts under the tongue at the same time. We're going to be doing CPR on them. Am I giving this medication by the right route of administration? Now, at the EMT level, that's not such a big deal. You don't have choices about routes specifically. The upper levels, I did hear something one time, I hope it's not true, that somebody gave some not oil glucose, but the black stuff, charcoal, through IV. Please say that's not true. Isn't that horrible? Yeah. Get some of this stuff in your veins. So, yeah, how'd they get that in there? It's a really big needle, wasn't it? Okay, What would be the potential risk to the patient if each of the 5 rights were not checked prior to administration? Potential risk? Yeah, overdose or kill them, who knows. Routes of administration, oral. What medications do we give on our list? Do we give orally? Aspirin, oral glucose, nitroglycerin, charcoal. Oxygen is not considered oral.
I was gonna ask, would that be?
Yeah, that would be respiratory. And
All of them.
actually, nitro itself is not considered oral because it's sublingual. It's either dissolved under the tongue or absorbed under the tongue. So that's sublingual. Sub is underlingual, means tongue. Inhaled, inhalation, where the medication is actually absorbed through the lungs. Usually we aerosize like the medication. Oxygen, of course, would be a gas, but the inhaler is a fine powder that's going to be aerosolized. IV would be injected into the vein. Oops, go back. Of these, which do you think is going to be have the fastest action?
Injection.
Yeah, oral is going to be your slowest because where is that absorbed? You know, when you swallow something entirely. Yeah, but IV or inhaled are going to be your 2 fastest routes of response. Intermuscular, we actually give our EpiPen intermuscular, inject that into the muscle. It's going to be faster than oral, but it's going to be slower than IV or inhalation. Subcutaneous, under the skin. What did y'all get before you come to classes? Your TB skin test, that's subcutaneous. That's right. Interosseous, you'll learn to do that later. We actually drive a needle into the bone, and we can give medications or fluids that way. Endotracheal, when they intubate a patient, put the tube down in the trachea, they can insert medications in there, so they're absorbed respiratory through the respiratory tract. So we have quite a few choices of getting medication. I think that's the last one. Yeah. Yeah. Quite a few choices how we're going to get that in. Pharmacodynamics is going to be the study of effects of medication on the body. So anytime you give a patient a medication, you need to think, what's the effect is this going to have on the body? That's what that means. And there's going to be specific characteristics about your patient that's going to affect how the medication is metabolized. You get an older person with a lot of liver damage, kidney problems, they're not going to be able to metabolize and get rid of the waste products as quickly as a younger person. So we can't give them the same dosage of the medication. Anytime you give a medication, you've got to document the status of the patient before you gave it, and then you give it, and then you're going to document their response to the medication. So anytime you do that, you have a lot of documentation to do. Before and after, pre-vital signs, post-vital signs, how much you gave, where you gave it, everything, the route. Common medications, are y'all dying? We'll sum this up. Analgesics are pain relief. That would be like aspirin, Tylenol, something like that. Antidysrhythmics are taken for cardiac problems, dysrhythmias. Anticonvulsions, your seizure patients will take anticonvulsives. Antihypertensives, you can figure that one out. High blood pressure medication, bronchodilators, antidiabetics, antidepressants. It's all stuff you know. In your textbook, they have this chart of different herbal medications that patients may take. When you're getting a medication history of your patient, you want to get the ones that are prescribed for them. So all the things that are prescribed for them, all the things that they actually take, prescription or non-prescription, And then any herbal medications or over-the-counter medications that they take. All of those are very important part of their history. Okay, we're going to go quickly through IV therapy here in about 5 minutes because we're going to do this in the lab. Ways of administering IV fluids. You may have a heparin or saline lock. You just have to read this stuff. Yeah. This is stuff you just can't tell you. You got to see it. We're going to look at our traditional IV bags. The bags hang above the patient, of course. Gravity is what flows that down. So in order to get the proper pressure gradient, you're going to have at least 30 inches above the patient. So anything that's lower than that, it's not going to flow into your patient. Administration set, it's going to be the clear plastic tubing, drip chamber. Yeah, I'm going to show you all that. Extension set, if you've got a patient that you're going to be moving around a lot, you may add an extra set in there so that you've got a longer tubing between your patient and the bag. They do that in the hospital a lot. We don't do it so much. I should have brought this. I'm going to show you all this in the lab. When you're maintaining an IV, you may actually, particularly at the advanced level, maintain an IV that's already in place, or you may do that at this level. You need to understand the way it all operates so that you can troubleshoot any problems. And we'll talk about this in the lab too. Sometimes you put on a constricting band, so that they can better see the vein, so they can hit the vein when they're trying to IV it. Sometimes they leave those in place. Nothing's going to flow when you've got a constricting band in place. Or if they've closed off the flow regulator, oftentimes when you're moving a patient, they'll close that flow regulator, and then once you get the patient, how you want them, you open it back up. If you leave it closed, nothing's going to flow. Don't ever run over it with a stretcher. It's always bad. Don't pinch the line under the backboard. Okay, here we are. You may need to have permission from med control to assist a patient with medication. So everything except oxygen we have to call for at the EMT level. Make sure you get a good sample history. Get all the medications from your patient. We can administer aspirin, oral glucose, activated charcoal, and oxygen. We can assist the patient with inhaler, nitroglycerin, and EpiPen. You got to know everything on those sheets, those little drug cards, little drug sheets I gave you. You got to know the indications. You got to know the contraindications, the actions, any untoward actions that occur. You have to know all that. You got to know the 5 rights of medication administration. You'll get that for the next 2 years. You got to reassess and you got to document. Okay, you got a patient complaining of chest pain. Here's some nitroglycerin, says a family member. Give him that. What do? He's got chest pain. I've got some nitro. Yeah, it's got to be prescribed for that patient. Just got to be. Yeah, and not expired. Okay, that is that chapter.
Which one's to read the system?
Let me turn this off real quick.
I have to go take my e-test.
You have to